Dear friends, in this video, we are going to discuss about some of the stroke mimics, which are of immense clinical importance in the neurological ICUs, particularly with regard to the features that sometimes makes diagnosis of stroke difficult in the midst of the various risk factors and predisposing causes. Let us start with a case. A 45-year-old male presented with sudden onset loss of consciousness for a day, who had a history of headache, lightheadedness, and weakness for 2 days, with a history of diabetes and hypertension for 5 years, for which he was on regular medication. And on examination, his blood pressure was slightly on the higher side, was 150 by 90 millimeters of mercury. Heart rate was 112. Respiratory rate was 20. Saturation was 90% on room air. And GCS was E1, V1, and M3. On CNS examination, the plantars were flexor. The deep tendon reflexes were normal. The superficial reflexes were sluggish. And focal deficit was present. The NCCT head was normal. The chest X-ray was normal. The 2D echo showed no regional wall motion abnormalities with an ejection fraction of 40%. The question comes, what is the differential diagnosis in this patient? Now, several conditions can present with acute focal neurological deficits. And besides stroke, they are commonly in order of their importance and epidemiological priorities includes hypoglycemia, post-seizure, which is also known as Stott's paralysis, several kinds of complex migraines, hemiplegic migraines, as well as intracranial and intrathecal tumors. But out of them, the most common conditions that are misdiagnosed as strokes are peripheral vertigo, seizures, and primary headache disorders. There are other stroke mimics which include intracranial space-occupying lesions, demyelinating disease, movement disorders, sepsis, delirium, metabolic disturbances, also hepatic encephalopathy, and functional psychiatric disorders. But you have to remember that stroke mimics may also present with positive neurological symptoms. And these positive neurological symptoms, like aura hallucinations or delusions, are different from negative neurological symptoms like lack of speech, lack of movement, etc. So even a patient with positive neurological symptoms can actually be a stroke mimic. If you look at the etiology of the stroke mimic, you can see the vast majority of the causes at the lower bottom are the peripheral vascular disease, almost equally important, but less than the peripheral vascular disease include the toxic metabolic causes and the seizures. Some, of course, are not so well defined, and functional disorders, migraine, collapse, sepsis comprise some of the other causes. So seizures, syncope, sepsis, migraine, functional disorder, and space-occupying lesions, and also metabolic conditions are most frequently diagnosed stroke mimics. Now, how should we evaluate a patient with suspected stroke mimic? That is, in whom we have excluded the cause of stroke, but we are not sure about whether the stroke mimic is actually present or not. Now, we have to remember that patients with sudden onset focal neurological deficit requires a blood glucose level check immediately. In alongside, they will require ancillary laboratory testing like basic metabolic panel, CBC, troponin coagulation studies, and ECG. NCCT head is the imaging of choice because of its non-invasive nature and rapid availability, widespread availability. But we have to remember a thing that it is not sensitive in the presence of acute CVA, especially during the first 48 hours. MRI here is more sensitive and specific to the diagnosis of ischemic stroke. We have to remember that patient characteristics like female sex, age less than 50, those with minimal risk factors for CVA like hypertension, atrial fibrillation, diabetes, and hyperlipidemia are more likely to have a stroke mimic. And also absence of intracranial atherosclerosis on CT angio, The lack of focal weakness on examination, history of migraines, seizure disorders, and prior psychiatric history are very important to rule out stroke mimics. There is also, it is to be noted that there is no specific historical detail or physical finding that can differentiate strokes from stroke mimics absolutely. So all the signs and symptoms needs to be collated and needs to be interpreted as in a proper perspective. Now, MRI is maybe negative sometimes in cases of posterior circulation stroke, but if you look into the hints, I'm coming to the hints later on, but if you look into the nystagmus, it can indicate if the nystagmus is direction changing, it can indicate posterior circulation stroke, can be dangerous. And if it is benign, then the nystagmus can be unidirectional, horizontal intensity changes with gaze in the direction of the fast beat. So in this case, it is benign, which is usually peripheral vestibular dysfunction findings. So head impulse, nystagmus, and test of skew, this assessment performed to differentiate posterior circulation stroke from peripheral vestibular dysfunction or vestibular neuritis. If we look into the demographic differences between stroke and stroke mimics, we find that all the stroke mimic patients have a much lesser NIHSS points. They are younger in age. They are more in female gender. The median time for presentation is much less. The blood pressure is lower, and also the unrevealed atrial fibrillation is lesser. Higher NHSS and female sex are more likely to have a stroke mimic. If you look into the risk factor differences between stroke and stroke mimic, we find that this smoking increases the risk of stroke, hypertension increases the risk of stroke, dyslipidemia increases the risk of stroke, and a lot of other factors like diabetes, IHD, atrial fibrillation, peripheral vascular disease, previous history of stroke. However, previous history of stroke does not make any difference, and it shows there can an equal proportion with stroke mimic and stroke. But there are certain like seizures in anamnesis, migraine, which increases the risk of stroke mimic over strokes. So cognitive impairment and history of migraine, these two history are very important. And if these are present, then there is high risk of stroke mimic in a patient with who resembles stroke but has all other investigations normal, who does not support the diagnosis of stroke. Now, as I mentioned about HINTS is a three-part neurologic examination, and it can detect, it has improved the sensitivity for detection of stroke in patients with acute vertigo or acute vestibular syndrome compared with CT scanning. It consists of head impulse test, nystagmus fast phase alternating with gaze direction such as central pause, and the test of skew. So in peripheral vertigo, there is no skew deviation on test of skew. The nystagmus is unidirectional or horizontal, and the head impulse test is abnormal, where corrective saccade to midline with rotation of head is there. In contrast, in central vertigo, there is normal, there is no corrective saccade. The horizontal and directional changing, vertical and torsional nystagmus is present, and skew deviation is absent. How to exclude functional neurological disorder as stroke? Patients are younger. They seem to be more likely to be female, usually presenting with more weakness and numbness with speech disturbance or reduced consciousness. And the physical examination shows inconsistent findings with repeated examinations. There is Hoover sign. Hoover sign is weakness of voluntary hip extension with normal involuntary hip extension during contralateral hip flexion. It is a very specific in the diagnosis of functional disorder. Therefore, previous psychiatric history is common, and symptoms are usually atypical and fluctuating, and also prognosis is poor. How to distinguish seizures from transient ischemic attack? So the deficits may persist longer in case of generalized seizure with reports of post-ictal deficits lasting for days in cases of Todd's paresis. Post-ictal dysphagia follows a dominant hemisphere seizures. If a previous seizure is unwitnessed, post-ictal paresis or aphasia are easy to misdiagnose as a stroke or transient neurological symptom of vascular origin. Then non-convulsive status epilepticus may present with prolonged aphasia or motor weakness. And in these cases, MRI diffusion-weighted imaging and multimodal brain imaging may help in the differentiation of ischemia versus seizure. So CT perfusion is a quick, fast imaging modality which can not only detect infarct size and penumbra, but also delineate conditions which mimic stroke. How to differentiate from stroke recrudescence? Recrudescence refers to the re-emergence of previous stroke-related deficits in the setting of metabolic, infectious, and toxic dysfunction, and the diagnosis requires MRI, which shows the old stroke and reveals no new diffusion-weighted imaging MRI deficits. Symptoms are mostly short-lived and shows improvement within 24 hours. The recrudescence can develop within days, within weeks to years after the previous stroke. The recrudescence under metabolic infection, fatigue, or sedative medications is likely due to functional suppression of the compensatory cerebral networks. And one thing one has to remember is that the presence or absence of headache is not specific neither to stroke nor mimics, including stroke recrudescence. So what is the effect of revascularization on the stroke mimics? A lot of patients undergo revascularization, and on these patients, if we compare, they have excellent outcomes after stroke mimics in comparison to stroke. And some of the patients also die. The risk of hemorrhage, thrombectomy, and thrombolysis is much higher after ischemic stroke. The outcome is always better in patients with stroke mimics. So if we have to follow the pathway, the clinical pathway, in patients with suspected acute stroke of less than 24 hours, doing a history and clinical examination with focus on established time on onset. If the risk of high probability of stroke mimic, we consider MRI and we consider blood test and bedside toxicology. In possible stroke mimic, we consider DWI and multimodal brain imaging. If stroke is confirmed, we continue acute stroke or thrombolysis pathway. If no imaging abnormalities, we should consider blood test and toxicology. If the patient is indicating acute isolated vertigo with no definite neurological signs, we consider MRI with diffusion-weighted imaging and consider Hint's maneuver. If stroke is confirmed and continue acute stroke or thrombolysis pathway, if no imaging abnormalities, consider blood tests and toxicology. In high probability stroke, onset less than 4.5 hours, we consider CTA to pick up the extra or intracranial stenosis and consider thrombolysis or thrombectomy. And if the onset is more than 4.5 hours, consider CTA and CTP to detect the penumbra. And if there is any sign, then to consider thrombolysis or thrombectomy. So the take-home message remains that peripheral vertigo, toxic metabolic changes, seizure, migraine, and functional disorders are the most common etiologies of stroke mimics. The stroke mimic patients seem to be younger with female predominance, with less severe symptoms compared with the other stroke patients. Mimics also have less vascular risk factors with a more frequent history of confusion or migraine. 1 out of 3 mimics is thrombolized with a very good outcome. Apart from the Hint's maneuver or the Hoover sign, there is no specific method in identification of mimics, and MRI diffusion-weighted imaging or perfusion imaging have a role in the setup of differential diagnosis, but they all merit further investigation. Thank you very much.